My first slide here just wants to explain what you already know. Whenever we look at first trimester, especially those who have done the first trimester scans in the transvaginal probe, you have seen something that looks like a cyst right at the top of the baby's brain. The rhombencephaly vesicle, it is normal part of brain development. There is nothing abnormal about this. So if you happen to do a transvaginal scan and you see something that looks a little bit scary, don't even worry. That's a cerebral hemisphere which is just developing. But the image you shall come to is this image. We are all aware of this image. I hope we are all aware now, but everyone who has attended the first trimester scan, you have seen us trying to produce this image on every baby. Probably when it comes to screening for major fetal defects in first trimester, this is the most important image that should always be done. What it may show us is showing us the midline. The coral plexus is here. The coral plexus is in the midline. If we see them the way we are looking at them, we know that we have ruled out two of the very bad central nervous system defects. We've ruled out anencephaly or crania, and two, we've ruled out holoprosencephaly. You will see for yourself how the images of holoprosencephaly look. So this is a very, very important image that we want everyone who, even if we ask you to do a first trimester scan, effort should be made to produce this image. It's a transverse view of the baby's head. The way you do head circumference is the way you will get this kind of image when you are doing ultrasound. Only in this case, you go a little bit higher, because you have the transverse plane here where you are seeing the ventricles. So, very important image. It should always be reproduced this trimester. We cannot say we've done a first trimester without doing this image if we want to screen for central nervous system defects. Then we have this image. Most of you have worked with us in the 11 to 13 scan. You have heard us saying they are giving the BS and the BSOB. And most of you have wondered and say, what is this BS, BSOB, and why are we doing it? If you look carefully, we have the thalamus there, we have the midbrain, then we have the brain stem. So if you look, this is the brain stem. The brain stem is tissue, it's not fluid, but in first trimester, it's too much. That tissue contains a lot of fluid. This is why it is looking hypoechoic to almost anechoic. It looks like a fluid space. But in reality, this is tissue. Well, that's the brain stem. You know, within the brain stem, there are so many centers. If you remember your physiology, I'm not sure it should be anatomy and physiology. That's in the brain stem with so many cells, so many, the nerves pass through there, many control centers, especially the respiratory center within the stem. Then see the line here, a white line. Behind this white line, we have the fourth ventricle. We have the fourth ventricle. On top, just this white line, you are lucky to see the of the fourth ventricle here. The fourth ventricle is fluid. It's fluid, which is just coming from the third ventricle to the fourth ventricle through the foramen of Lucifer, right? Romondra. Can't remember. But the fourth ventricle. And have another white line, an echogenic line, which is a tissue. Then behind it, we have the cisterna magna. This is the membrane. Then we have the cisterna magna space. So when we are saying we are doing the brainstem to brainstem occipital bone ratio, in other words, we are measuring the thickness of the brainstem. We are comparing the thickness of the brainstem to the space occupied by the fourth ventricle cisterna magna space. So what factors will influence this space? There is a meningocyte. When the myelomeningocele will not allow the nerves will be tethered or stuck. So if you look carefully, the midbrain here looks a little bit thicker than the brainstem. So in cases of myelomeningocele, there's going to be tagging or pulling of this part so that the midbrain will come down here and make this place thicker than what it should be. So doing the brainstem to brainstem occipital bone ratio, it allows us to screen for baby who have myelomeningocele, spina bifida. That is, if this space is bigger, if the ratio is greater than 1 or approaching 1, then we have to investigate the spine. Then when you cisterna magna and the ventricle, sometimes we have very early obstruction to the flow of cerebrospinal fluid. There is dilatation of the fourth ventricle. So that means this space is going to be thicker and push everything up and make the space going to be narrow. They used to call it intracranial translucency. As it suggested that you should just measure the fourth ventricle here, but sometimes it could be dilated. So the ratio will even go lower than, around 30 to 50% weight normally is. Alternatively, cysts where the cisterna magna is dilated, like this. In one woman, we had twins. Unfortunately, she didn't come back to us. So where there was a posterior fossa cyst. So all these images, when we are doing brainstem to brainstem occipital ratio, what are we trying to do? We are trying to screen for major central nervous system. Then we already know this image here. We are aware of it because you guys are always measuring the circumference. But what is important when you are looking at this image from the anatomy point of view? We are saying normal because you've seen that there is a midline, the anterior interhemisphere here, which is continuing. And you can see it continuing in the middle after this box. The box of the cavum septum pellucidum should always be seen. If you can't see the box of the cavum septum pellucidum, you cannot pass that baby's head is normal. You cannot the brain, then the brain is normal. And a further evaluation is required. Because the baby could have access to the corpus callosum, or the baby could have optic dysplasia. So This is to be seen all the time. The cavum septum pellucidum, and we have to see the anterior horns as well. Then when we move from there, we should see the posterior horns of the lateral ventricle and the choroid plexus here. So this is the choroid plexus, the posterior horn of the anterior ventricle, and you should be able to clearly demarcate it. And of course, and the cranium, because if it is there, then you need to think of neuronal migration disorders. So these are the images that are used to. Then we have another image, which probably some are not doing. That is image C. I just want you to look at the planes. These are the planes. I'm not going to bother you with this other, because I think you all know how to assess it. The thalamus, you just go a little below this, and you are going to see the thalamus, because that's the level of the thalamus where there is a third ventricle here. This is the ventricular system which you are looking at here. That's the ventricular system. So these are the posterior horns of the left ventricle, and this is the third ventricle in the center. Then there is a foramen, and then we are going to have the fourth ventricle here. That's the fourth ventricle down there. So this is how the system is arranged. We have the lateral ventricles here, and then we have the body, then the posterior horns. The ones we measure are this part of the horns. Those are the posterior horns there, right at the back. Which I'm pointing to you here are the ones you see here. It's bilateral. This image is like this, is bilateral. It's both sides, not like you see it here. So we have ventricle, then the fourth ventricle down there. For us to be able to see the you can see you have to shine your probe on this head. Transcerebral plane, you have to rotate your probe from the BPDH circumference plane and go down to the baby's occiput to see the cerebellum. Once you see the cerebellum space, this will allow you to assess the posterior fossa, where we have the cerebellum and the cerebellum vermis and the other lobe and the cisterna magna space, and also the knuckle fold, but the knuckle fold is not part of the CNS system we are talking about. In front of the cerebellum, we have the cerebral peduncle, these two structures there. And of course, we have the slit of the third ventricle, which you all can also see at the level of the transthalamic plane. At the level of the transthalamic plane, you see poorly the ventricles because you are a little bit lower than where it should be. The third ventricle should never be dilated. It should always be a slit. The cerebellum, you should always see the two lobes are interrupted by the vermis in between them. And the cisterna magna space should be measured and should not exceed 10 millimeters. So, in other words, we expect everyone to scan to this level, to improve themselves to reach the level. Let's go to the correct measurement of the lateral. This image is showing us the wrong measurements. Let's start in terms of how it should be done. You can see this one is too much inside. So you don't put your calipers inside the lateral ventricle and you don't measure at the periphery there. Now right? You can see these ones are outside the walls. You put them outside. Don't put them in the middle of the wall, but they should sit on the wall like you're doing a nuchal. I'm sorry to say this zoomed one is not the correct one, because it should really sit on the wall like we are doing the nuchal. If you look at image there, you can see it's fairly sitting wall. Maybe the lower one is not quite, but you should make sure it's seated on the wall here. Wall, and you zoomed well enough, like see here, one of our images where we zoomed it well enough. And where should it be measured? it should be measured at the level of the occipitoparietal fissure. This is the occipitoparietal fissure. You see this dimple there, this dimple of tissue. This is where it should be measured. Someone may ask and say, what is wrong with me measuring it here? What is wrong with me measuring it here? Remember, in fetal medicine, as you will see when we discuss the condition, the natural history of the condition has to be observed. When you are saying we observe the natural history, for us to be able to that mild ventriculomegaly self-resolves on its own in about 80% of the cases, it's because those babies were followed up resolution of business. For us to be able to monitor and say, are we getting worse or are we getting better? Even if we are not there, the person saw the patient the first time, after that, the same measurement at the same place that you measured, inform the patient that, look, we are getting better or we are getting worse. What does it mean? This means we should at the same level so that when the patient comes to us, we're not going to tell the patient that is getting better when it's not, when it is still the same. So it should be measured at the correct level. For you to check, you need to issue your beam is perpendicular. If you do it in second trimester, it's not a big issue. But in third trimester, you may need to tilt the bit so that you see the walls and also take advantage of this at the back here. Both assist, we have already asked you at the back to see the ventricle once you have this one. There is an action which I did not describe, which probably I need to show you on these images. So if you look at the transthalamic plane, you can see that there is a dimple on the brain there. This dimple is called the Sylvian fissure. Sylvian fissure is a marker of brain dilation or brain development. You know the brains are convoluted. They are like folding onto itself. This folds onto itself. It's the same thing we see microscope section. This dimple is called the fissure. This fissure, it tells us if the brain is developing normally, because the brain is supposed to unfold on itself. You can also see it here. So the angle, this angle is the one that tells us if the brain is progressing the way it should progress. So how should the brain progress? At 20 weeks, normally this part of the brain is an open angle, as you can see there. It's just an open angle. Then at 22 weeks, it takes like a 45-degree angle as it unfolds. The brain is now unfolding on itself. Then at 24 weeks, it takes more of 90 degrees. Then at 26 weeks, the temporal lobe covers posterior lobe here. So the unfolding starts. Then at 28 weeks, the temporal lobe covers half. As it unfolds, you can see it's folding here on itself. Then at 32 weeks, the temporal lobe is totally, you can see they are meeting here. Is now covering the posterior. That is it. 32 weeks. So this is a very important component because we are going to be covering migration, neuronal migration disorders. So remember the Sylvian fissure, this structure that looks like a box that is should be monitored whenever you are doing a scan. Always check and say, is it growing normally? Is there evidence that the brain, the neuronal migration process is happening normally? So I've already described the ventricular system, that it looks like this. The ventricular system, this is the posterior fossa, the third ventricle is what I showed you, then the cerebral aqueduct, and the ventricle here. Then we have the foramen of Lushika, between the lateral and the third ventricle, and the foramen of Monroe's. So whenever we are interrogating the ventricular system, we need to be aware that it's not just the third ventricle. The ventricular system is connected from the lateral ventricles. There are two of them. They all drain into the third ventricle. Through the cerebral aqueduct, they drain into the fourth ventricle. Then from there, they go to the spinal space. So when we're interrogating the system, we are asking ourselves and say, is there a blockage at any point? Could there be a blockage between the drainages of the cerebral spinal fluid from the lateral ventricle to the third ventricle? There the blockage of the fourth ventricle, or is there a blockage at the level where the spinal fluid goes to the spinal space? Okay, at the level of the cisterna magna, at the level of the foramen magna, due to the TEG we see in myelomeningeal cells. So the whole system may be dilated, or unilateral dilation may occur, or two of the ventricles may be dilated, or three of them may be dilated. So they are communicated and they can all get blocked. So whenever we are interrogating, we need to check. Then of course we always want to see the periventricular space. When we are doing this, which one is the periventricular space? This periventricular space, the space around the ventricle. Sometimes it will be too calcified in cases of touching pain, but the ventricular wall itself may have some beads. So we also need to check and make sure that the wall is as smooth as it should be. I will skip this. Let me go to the ventriculomegaly before people forget about ventricles. So ventriculomegaly, how common is it? I think this will be my last slide for today. Our time is up. How common is ventriculomegaly? It is as common as 1 in 100 at 18 to 23 weeks. And at birth, it is as common as 2 in 1,000. In most hydrocephalus babies. So this is a very common question. If we are seeing lots of anomaly scans, this is why it is important to be able to screen for it. And what causes ventriculomegaly? The most common cause for mild ventriculomegaly are chromosome abnormalities such as trisomy 21. So whenever we see a woman with ventriculomegaly, we always want to discuss them, the possibility of the baby having trisomy 21. We should offer screening for trisomy 21. Genetic abnormalities may also cause, there are some inheritable ventriculomegalies, more so in males. So whenever we see it, we also discuss the issue of genetics, and we also want to know the head sizes in the family, and so forth, to know if somebody else has had ventriculomegaly in the families. Intrauterine hemorrhage, if the baby is for one reason or another, whether it is an issue of platelet or any other issue or trauma, hemorrhage tends to cause unilateral ventriculomegaly, where it blocks one side of the lateral ventricles. So ventriculomegaly secondary to hemorrhage is unilateral. Congenital infection, TORCH, toxoplasmosis, cytomegalovirus, rubella, they may block these aqueducts here due to inflammation. So they may cause ventriculomegaly. Diagnosis, if we measure the posterior one of the lateral ventricle, and it is more than 10, it is between 10 to 15 millimeters, that's mild to moderate. If it is greater than 15, that is severe ventriculomegaly. The association with between 1.5 to 2% if it is, but it's about 9 to 36% if it is associated with other defects. The management involves offering these women karyotype and also screening for toxo and CMV. There is no fetal therapy. What we are saying is there is no treatment that we can offer in uterus for ventriculomegaly. Then the prognosis depends on the etiology and the associated lesions. But what we know is that this condition is associated with severe and mental handicap if it is a severe form of it. The mild case is in about cases, more so if we have ruled out chromosome abnormalities. So ventriculomegaly, in mild cases, itself resolves in about 80% of the cases. But if it is in severe form, while there is an obstructive pattern, we know that the radiological damage may vary from between 25 to 50%, and these babies are maybe mentally inflamed. To just show you some of the images of ventriculomegaly, these conditions you have seen them a lot. In first trimester, we refrain from diagnosing ventriculomegaly because the false positive is very high. So we even bring these babies. We followed up babies who were suspected of ventriculomegaly in first trimester, and they turned out to be fine. So whenever you suspect, you have to be very cautious. The woman has to be told that the false positives are very high. All we need to monitor, probably check again in 16 weeks. So these cases of ventriculomegaly, in this case, that the lateral wall is dilated, the third ventricle of the ventricle here. Here you see that ventricular lateral walls are very much dilated. This is a case of severe. You see the distortion of the brain, as you should see here. And when you look carefully here, you are going to see that even the fourth ventricle is dilated. So is the third ventricle and the lateral, posterior and anterior horns of the lateral ventricle, and distortion of the system of cover up there. It's not clear where it is. So these are cases of severe ventriculomegaly. So to just end the talk for today, sorry for starting late and we didn't cover. We have 3 weeks to finish this talk on just central nervous system. So next week, hopefully, we cover more ground. To summarize, on central nervous, on ventriculomegaly is very common. It is imperative that we now, all of us, we begin to migrate and begin to assess the posterior horn of the lateral ventricle. We should assess the lateral ventricle whenever we are scanning. Most of our babies we see having done anomaly scan routinely. So it doesn't matter that you are seeing a patient at 39 weeks or 40 weeks. You have a habit of checking the ventricles so that we can increase detection rates of ventriculomegalies. So the ventricles measured, whether you are doing just a routine, because it doesn't take 2 minutes to measure this. So whether you are doing a scan, you have the tendency of checking the posterior, the ventricles, so that you are sure that the ventricles are normal. Thank you so much. Without wasting your time, I think we'll call it quits. Sorry for starting late. Hopefully next time we won't have the internet challenge. Otherwise, enjoy your be directed in the group and can always be asked in the next meeting.